Hello, everyone. I'd like to thank you all for joining us on today's session on recent advances in treatment research, sponsored by the Royal Canadian Legion Dominion. Your facilitator for today is Debbie Turner, Director of Veteran and First Responder Programs. My name is Diana Vince here with you at Mood Disorder Society of Canada. I will now hand it over to Debbie to continue the session.
Thanks, Diana, and welcome all to the second in the series of three live seminars that MDSC will be hosting this winter. And a special thank you to our sponsor, the Royal Canadian Legion Dominion Command. Let's start by honoring our territory. We acknowledge that we live, work, meet, and travel on the unceded traditional territories of the Indigenous people, First Nation, Métis, and Inuit people. They are the traditional guardians of this land that we call Canada. We value their wisdom, we honor, and we respect them. And let's just go now over to a few housekeeping items. So your microphones are muted as the session is being recorded, and the recording will be available posted on the MDSC website in a day or so. The chat function has been disabled, but we will be posting towards the end of the seminar an anonymous survey link in that chat, and we'll let you know when it's up. Time permitting, if you have a question for our speaker, please do place it in the Q&A located at the bottom of your screen. And by all means, please take care of yourself. Some of the content may be sensitive to you. By now, you all know that MDSC has been providing Canadians from coast to coast with mental health services and supports for well over 25 years. So we'll go to the next screen, Diana. We currently offer 8 unique services and supports for veterans and their family members for free. Please make sure you visit our website. So at this time, I'm delighted to introduce our keynote speaker for today, Dr. Dawn Richardson. Over to you, Dawn.
Okay, thank you so much. I just wanted to make sure that I can actually advance the slides. And thank you so much, and especially to the Legion Dominion Command for providing this opportunity, and also the opportunity to talk about the psychiatric management of military-related PTSD. I've done this type of talk to service providers, to clinicians. I've also done similar talk to families and veterans, and so hopefully we'll have time in the end to also have some good questions and discussions. A bit of the agenda. I'm going to do a bit of background about PTSD and OSI, talk about PTSD and risk factors, very high level of how we would approach treatment, and also have an opportunity to talk about some of the future directions or innovations in treatments. So first, a little bit about what we would call veteran identity. There are certain definitions. A veteran is defined by Veterans Affairs Canada as any former member of the Canadian Armed Forces who successfully completed basic training. As a veteran who is somebody who's serving in the Canadian Forces can be released voluntarily due to medical reasons, or if their service has ended. And this is from a little bit old now in terms of statistics, but in 2021, there were about 461,000 Canadian veterans, being mindful that not all veterans in Canada are clients of Veterans Affairs Canada. Many veterans have been released from the Canadian Armed Forces and are not receiving any additional services. We also want to acknowledge RCMP veterans, as Veterans Affairs Canada provides benefits and services also to former members of the RCMP. And also being mindful that even though someone transitions from active service to civilian service, they do not shed their kind of military or RCMP identity. I'm going to ask for the next slide because I can't, my clicker isn't working anymore. So in terms of veteran culture, there's certain things to be mindful, and this is something that we do try to inform and teach, especially service providers and clinicians, the whole concept of unlimited liability. Service members may be ordered to injure or kill and may themselves be injured or killed in the service of Canada. And these orders are mandatory. So refusal of a lawful order is not an option. And every decision can carry both life and death consequences. The other concept is mission first and self last. So duty to country, unit, and fellow soldiers takes precedent over personal needs, and the collective objectives will outweigh individual safety or comfort. And why this is important to understand both unlimited liability and mission first and self last is that this has implications in treatment seeking behavior. In that often what we do know, both from research and clinical experience, is that often if someone is injured, whether it's a physical injury or a psychological injury, they'll often push through kind of this push through mentality. They'll often either minimize their symptoms or avoid reporting symptoms or asking for help. And this persists not only while they're still in service, but even after their release. Next slide, please. There's certain definitions to be mindful. Everyone here probably has heard the term operational stress injury. This refers to any mental health condition resulting from operational stressors experienced while serving in a professional capacity in the military, public service personnel, or RCMP. And this term is a Canadian term that was coined by now retired Lieutenant Colonel Stéphane Grenier. And he developed this term in order to fight stigma against mental illness. And from the development of this term is that someone could be on operation and you could be physically injured, but you can also have a psychological injury. And this term is not a diagnosis, but does include anxiety disorders, mood and trauma-related disorders such as PTSD or major depression. The other concept to be mindful of is the whole area of moral injury, and this refers to psychological, emotional, or spiritual distress that arises from actions or inactions that violates one's moral or ethical belief. This is common in the military, veteran, public safety personnel, and also in RCMP. And here the overwhelming kind of symptoms or feelings people have involves guilt, shame, betrayal, including institutional betrayal, and a loss of trust. Again, moral injury is not a formal diagnosis, but can contribute to PTSD, depression, or other mental health challenges or conditions. Next slide, please. When we look at how common is PTSD in Canada, as you can see from this bar graph, in the general population, about 9%, in the Canadian forces, about 11%, and in the veteran population, about 14%. There's also been some studies that look specifically at RCMP, and here the rate's much, much higher, around 30%, in paramedics about 24%, and then in firefighters about 13%. Some of this discrepancy that you see from both much higher prevalence has to do with the way the study was completed. Some of them are national surveys, while some are maybe more representative of smaller groups. Next slide, please. When we look at risk factors for developing PTSD, they can be generally divided into pre-trauma factors, events or things that occur before the traumatic event. Then there's the traumatic event itself, which is the peri-traumatic factors, and then there are all the events that contribute after the traumatic event or post-trauma factors. Being mindful that when we look at gender, women have higher risk of developing anxiety disorders and also PTSD, a history of past psychiatric conditions, history of childhood abuse or neglect, or prior adverse events are all factors that are risk factors to developing PTSD if you're exposed to a traumatic event. Then there's the trauma severity. Obviously, the more severe the traumatic event, the more likely that you will develop PTSD. And then there's the events afterwards, such as stress and lack of social support after the traumatic event. What this slide really shows is that the events that are the factors that are most important for somebody developing PTSD after exposed to a traumatic event are those afterwards, such as stress after the event or the lack of social support. Next slide, please. In terms of the general kind of criteria for PTSD, many things in your life can be traumatic, but according to when we look at the diagnosis, it defines a traumatic event quite specifically as being exposed to actual threatened death, serious injury or sexual violation, or learn that this had occurred to a close relative or a friend, or repeated exposure to the details of the events. This is really to make it inclusive for individuals might not have been exposed directly to the traumatic event, but might have been on jury duty where they are getting the details of the event, or they might have been doing an investigation or getting all of the details, or in individuals that are in first responders, they might have been listening to a traumatic event in real time, even though they themselves are not at risk. Next slide, please. And then when we look at the core symptoms, they fall into four main categories. One, very common for everyone, if you're exposed to a traumatic event, is reliving it, so the re-experiencing symptoms. And these include the intrusive thoughts and memories of the traumatic event, nightmares, reliving it at night while you're trying to sleep. Flashbacks really means reliving the event in real time today, getting the sights, sounds, or smells. And then things that look a lot like anxiety, becoming distressed, emotionally distressed at when you get reminded of the event, either feeling your heart pounding, chest tightening, or feeling hot. And then also physiological reactions, which are some of these physical symptoms people can get, as I've mentioned already, their heart pounding or feeling kind of short of breath, things that look a lot like an anxiety attack. Not uncommon, but for humans and for most animals, if something is upsetting, we tend to want to avoid it. And avoiding thinking and talking about the traumatic event, or avoiding specific activities or places that could remind you of the event. Then there's the whole area of emotional numbing that can occur. And one is amnesia, which is difficulty remembering important aspects of the event. Full amnesia, which is forgetting about the traumatic event, more common in people who are much younger. Strong negative beliefs or expectations, distorted blame about yourself or others, strong negative feelings, especially guilt or anger. Then there's the emotional numbing that having difficulty having loving feelings for those close to you, loss of interest in activities that you might have enjoyed in the past, resembling a lot of symptoms of depression, and feeling detached, not having kind of a lot of emotional reactivity. The symptoms that are kind of what we would call hyperarousal and reactivity symptoms are the symptoms that often get people to seek help. The irritability, the anger, risk-taking behavior, taking kind of unnecessary risk, hypervigilant, constantly scanning for threat, an exaggerated startle response. So if you hear a loud noise or a bang, becoming much more kind of startled than you would have had an experience you would have had in the past. Difficulty concentrating, difficulty staying focused, and of course, insomnia, difficulty falling or staying asleep. But often what we hear is people being afraid of going to sleep because they might be reliving the event. So you need at least one re-experiencing, one avoidance, at least two negative cognition or emotional numbing symptoms, and two hyperarousal. And if you have those symptoms for more than 1 month, then it's considered consistent with PTSD. Next slide, please. As I mentioned, to have the diagnosis, it needs to last at least 1 month. It has to cause clinical significant distress or difficulty in functioning. And then there are areas that we look at, whether you have significant dissociative symptoms or delayed expression. That means that if you have these symptoms, but it occurred more than 6 months after the traumatic event. Next slide, please. Then the whole area of comorbidity. Comorbidity in PTSD is what we would call more of a rule than an exception. Comorbidity, if you have PTSD, what's the likelihood that you also meet the criteria for another mental health or physical condition? One, in terms of mental health, major depression would be the most common comorbidity. Substance use disorder, whether it's alcohol or other drugs, other anxiety disorder. We also know that suicide and suicidal behavior are common with those who have PTSD. The whole area of problematic anger and psychotic symptoms can also occur. And non-psychiatric, this is the whole area of mild traumatic brain injury and physical injury. Often the TBI or the physical injury is the same event that contributed to the PTSD. Chronic pain, we do know people who have PTSD are more likely to have chronic pain, and then other physical health conditions that I'll go into. Next slide, please. Some of these other health problems, PTSD often presents with musculoskeletal conditions, gastrointestinal decisions. This is people presenting with increased gastroesophageal reflux or severe heartburn, abdominal cramping, cardiovascular disease. A lot of research on people who have PTSD, higher risk of having heart disease, chronic pain, which I mentioned, and a lot of studies that looked at sexual dysfunction, and people who have PTSD increased risk of sexual dysfunction. And something that I'll mention later is that's often, in terms of antidepressants, are often contributing also to these to worsening of this condition. Next slide, please. So when we look at treatment, next slide. Most of the treatment guidelines that have been developed, and there are treatment guidelines that have been developed through the US National Center for PTSD. So these are the Department of Defense Veterans Affairs treatment guidelines. There's guidelines that have been created by the American Psychiatric Association. There's Canadian guidelines, there's UK guidelines, and Australian guidelines. Almost all of the guidelines that have been established will recommend talking therapy, psychotherapy, and pharmacotherapy or medication. The difference tends to be which one do they recommend as first line and which one do they recommend as second line. Almost all of the guidelines that were created by non-medical associations tend to recommend psychotherapy first, medication second. And most of the evidence would show in general PTSD, talking therapy tends to be more effective than medication in general. Can you go back to the past? However, what we've seen and what we do know is that in military-related PTSD, in general, they respond less to both medication or psychotherapy. More recent research that was done by my colleague who's joined here, Dr. Jenny Liu, looked at all of the studies, but really focused only on those that have military or combat-related PTSD. And what was discovered from this published study is that medication or psychotherapy are generally equally effective, but that it's the combination that actually was demonstrated to be more effective. And this is what is showing on the opposite side of the slide here. Next slide, please. So where do you start? Next slide. In general, when we're looking at basic principles of treatment, there's things that you do at the beginning, there's things that you do in the middle, and there's things you do near the end. And I have different arrows because sometimes you need to go back. At the beginning, there's stabilization. Then the next part is trauma-focused psychotherapy. And then finally, what we would call rehabilitation or reintegration. Next slide. So in stabilization, the primary goal is to improve current functioning. And in my case, for a lot of clinicians, is to establish a trusting relationship. And in this area is providing education. The signs and symptoms that you're coming here today has a name, and it's called PTSD. Much in the same way that if you go to your doctor and you have a sore throat, and they examine your throat and they might do a throat swab, they'll say, this has a name, and from the test that we've done, it's called strep throat, and we have active and we have good treatments for it. That's the main message about psychoeducation. Also part of this is teaching problems, strategies, also a lot of work on anxiety management skills. And it's also a time to focus on what I've mentioned before, the comorbidities, managing acute symptoms, especially severe mood symptoms and depression, suicidality, trying to improve and assess sleep disorder, work at extreme irritability, and also manage if there's other significant symptoms. Next slide. In terms of medication, next slide. In terms of the primary recommendations that for PTSD is the use of antidepressants. Even the antidepressants have been shown to decrease all of the symptoms of PTSD, even in those who do not have depression. So being mindful of that. There are medications that are indicated, and these are what we'd call SSRIs. I won't go into a lot of details, but both sertraline and paroxetine have Health Canada approval for PTSD, and they're also effective for the comorbid mood and anxiety symptoms. A lot of the treatment guidelines have also included what we'd call dual-acting antidepressants, especially venlafaxine. And as a result, venlafaxine is also considered a first-line medication treatment by some of the more guidelines that have been established. Because of this, and because also a lot of people who have PTSD also have other comorbid depression or anxiety, they're often used. Other dual-acting antidepressants might also be used at the beginning. Next slide, please. In terms of treatment-resistant PTSD, what we mean by that is that individuals who have been on multiple treatments but have not responded. However, there's no widely accepted definition of treatment-resistant PTSD, and unfortunately, there's no treatment algorithm to manage PTSD. Treatment-resistant PTSD. What we do know, though, is that a lot of individuals might have tried multiple different treatments, but we're unsure is how long they were in the treatments, and did they, if it's for medication, were they on the medication long enough in order to get a benefit? And the same thing, did they get enough psychotherapy to get a benefit? However, there's a lot that we can learn from the depression literature, depression research, in order to help guide us with those individuals who are not responding to first-line treatment. Next slide, please. This is a kind of a slide that was developed by CanMat and a Canadian organization that specifically looks at treatment-resistant depression. At the beginning, you want to make sure that if somebody's not responding to first-line treatments, you want to make sure that you have the correct diagnosis, and that you've also treated the comorbidity aggressively. You want to optimize the dose, and making sure that you assess the response with what we call objective tests, such as questionnaires. The same way that if you see your family doctor or your nurse practitioner because your blood pressure is elevated, you want to know what your blood pressure is, and if you're trying a medication, or if you're changing your diet or doing weight loss management, you want to have your blood pressure checked again to ensure that the scores that you're getting on the measurement are now within the normal range. It's the same in mental health. There are questionnaires for depression, anxiety, and PTSD that can be repeated in order to ensure that the treatment is being effective. You want to assess response within 4 to 6 weeks. And then if the person is responding well, then you keep them on that same medication. And the literature, or if we look at what we know from depression, usually staying on a medication that you responded well to for at least a year before deciding to discontinue or come off the medication. Somebody's not responding, then you can switch to another medication. You can combine two medications, and you can also combine medication with psychotherapy. And of course, I have here, because I do talks to primary care clinicians, is sometimes you need to refer to a specialist in order to ensure that you're not missing out on other diagnoses. Next slide, please. So when we look at switch or combining antidepressants, commonly adding another antidepressant, bupropion or mirtazapine is often added. For individuals that have quite a lot of hyperarousal or irritability, then they're adding a mood stabilizer, or what we'd call atypical antipsychotics. There's some good research that demonstrated a specific antipsychotic, specifically brexpiprazole and sertraline, was demonstrated to improve symptoms of PTSD. And for that mood instability or impulsivity, anticonvulsants have also been used. Here I've listed carbamazepine, valproate, topiramate, and lamotrigine. Topiramate is often used, but it also has a significant side effect of cognitive, makes it harder for people to concentrate and focus and word find. So for individuals that might have a TBI, probably a medication to avoid. Next slide. Nightmares and insomnia, so nightmares and difficulty falling or staying asleep, has been shown to be the most prevalent or most common symptoms in individuals' PTSD. There are algorithms that have looked specifically at that, meaning that if somebody's presenting primarily for nightmares, there's medication that has been shown to be helpful, such as prazosin, which is an old antihypertensive that has been shown to decrease the frequency and severity of traumatic nightmares. Nabilone, which is a synthetic cannabinoid, has also been shown to decrease the frequency and severity of traumatic nightmares. For people who are presenting primarily with difficulty sleeping, not necessarily nightmares, there are medications specifically to address sleep, including zopiclone. There's also antidepressants that are used at low dose, such as mirtazapine and trazodone to help people sleep. And then there's newer kind of medications to help improve sleep, such as lamberexant. Next slide, please. Some of the alternative or emerging therapies that you might have heard of, one is repetitive transmagnetic stimulation, or RTMS. This has been approved in Canada for treatment-resistant depression. There has been some studies that have been quite small, but have shown it's been helpful for symptoms of PTSD. The key here is that sometimes targeting symptoms of depression can also allow an individual to better cope with their symptoms of PTSD or to benefit greater from the psychotherapy. So that's an option that's also available. Ketamine, which is an NMDA receptor agonist, and this is also indicated in Canada for treatment-resistant depression, especially the intranasal formulation, but off-label it is also used to treat treatment-resistant depression. Some of the studies have shown that the intravenous appears to be more effective than the intranasal esketamine. Then there's the whole area of psychedelic treatments, which includes psilocybin or MDMA, and these have been investigated for PTSD with and without depression. And most often, most of these studies are done in conjunction with a type of psychotherapy. Currently, they're still in the investigational stage, but they're demonstrating very promising results. Next slide. We wouldn't be in Canada without talking about cannabis for PTSD. A lot of veterans, and this is from studies that have looked, are using cannabis, either cannabis for medical purposes to treat symptoms of PTSD, or might be using cannabis recreationally. Some of the benefits that have been reported in terms of reducing anxiety, decreasing or improving their sleep, and also decreasing nightmares. The other thing to be mindful is that most of the studies have been small and often are patient reported. However, there is a perception that cannabis has less side effects than some of the other medications that are available. In terms of the drawbacks, as I've mentioned, most of the evidence are from what we'd call low quality or high risk of bias observational studies. There are some side effects in terms of memory impairment, dizziness, and there's been some report that it can increase or worsen anxiety. There's also the potential for misuse and addiction. And there's been some studies, primarily in the US VA, that demonstrated that it can worsen some psychiatric conditions, specifically increasing the risk of psychosis and suicidal ideations. Next slide, please. Keeping in mind treatment, medication, adherence, meaning that medication will only be effective if they're taken regularly. So very, very important if you're a prescriber to ensure that you're asking if they're taking the medication as prescribed. And for individuals that are those who are using the medication, to ensure that you develop a trusting relationship so that you can share problems or concerns that you have about the medication, especially side effects, with your prescriber. But most things to kind of keep in mind is to start low and to go slow, but to gradually increase the dose until you've reached kind of the maximum benefit from it. Next slide. The whole area of trauma-focused psychotherapy, which is kind of the next phase, the primary goal is accepting the trauma as part of life's experience. So moving away from being haunted by the past and becoming fully engaged in the present. What is often described as somebody experiences a traumatic event in kind of their book of life. And this traumatic event might have occurred in like chapter 5 in their life's journey. Often people with PTSD can get stuck in that chapter 5 while everyone else in their lives continue to be moving on to chapter 6, 7, and 8. And the goal for, in terms of the talking therapy, is not to remove that chapter 5, but to be able to talk about that event and also see it as part of your past instead of reliving it as in the present. Most of the treatments, especially in Canada, is talking about the traumatic event and its meaning. And I've listed here some of the 3 that are kind of the top recommended psychotherapies: prolonged exposure, cognitive processing therapy, and EMDR. This is not to discredit that there's also many other ways people have recovered from the traumatic event, especially in art. Some people have written about it, or some people have done kind of their own recovery journey. But these are the primary kind of evidence-based talking therapy. Also being mindful that moving into this next stage is client readiness, meaning that the individual is now ready to be talking about the traumatic event. And then there's an agreement also with those who you might be living with, so that they are also aware in terms of family members or spouses that you're going to now be moving to a next stage of talking about the traumatic event. And that's what I mean about agreement to pursue this. And also during this time is also to assess and treat comorbidities, because sometimes other comorbidities might also reappear. Next slide. The primary evidence-based psychotherapies, prolonged exposure. Basically, this involves talking about the traumatic event and over again, while also in a safe environment, and also having the anxiety management strategies to be able to kind of calm your body while talking about the event in a safe and supportive environment. And the basic premise for prolonged exposure is that it's the avoidance of talking about the event that actually reinforces this anxiety. So talking about the event and being exposed to it over and over again over time, listening to it over time helps diminish the symptoms of PTSD. In terms of cognitive processing therapy, this focuses on the thoughts and feelings related to the traumatic event and what interferes with the natural recovery. So individuals who have been exposed to a traumatic event might have changed the way that they view themselves, others in the world, and it looks at avoidance behavior, distorted beliefs about the trauma, and how this has been generalized kind of in your other behaviors or actions on day-to-day lives. The final one, which is eye movement desensitization and reprocessing, EMDR, this is a different type of therapy which focuses on the traumatic memory while simultaneously having bilateral stimulation. Most often it's eye movement, but it could be alternating sounds or tapping. This type of treatment does not involve talking in detail about the traumatic event, and it does not involve homework. The reason that there's different types of psychotherapies is that you might have tried one therapy and either did not find it beneficial or found that it wasn't something that you could pursue, and being mindful that there are other types of psychotherapy. So important to be mindful that if you didn't respond to one type, that you might respond to a different type of talking therapy. Next slide. In terms of rehabilitation and kind of that reintegration, being mindful that this type of work whether you're an individual that cannot be done alone. So treating both, I have here PTSD, but also some of the other comorbidities often involves a team. So it might be like myself, seeing a psychiatrist. You might also see a psychotherapist or a psychologist or another mental health professional. And you might also have a primary care clinician or a family doctor involved or an OT. So it's being mindful that there might be other individuals within your healthcare team that's providing that support. Very, very important to engage and be mindful of engaging the family, being mindful that if one individual has PTSD, it has a significant impact on the family. Peer support, also being mindful that the pharmacy is also there to support individuals, especially if you're having some side effects or if you want to discuss potential kind of different medications that are there, especially if you're on multiple medications. So important to get medication from the same pharmacy. There's shared care where you might be seeing a psychiatrist, but most of the treatment is being done by the primary care clinician. There's vocational rehabilitation, which is working with you, individuals have PTSD, whether it's going back to school or in retraining, and then being mindful of establishing a relapse prevention and crisis management, being aware of the signs and symptoms of relapse, and also developing a secure plan. Next slide. In terms of future direction, there's certain things that are currently being worked on, matching or what we call personalized treatments. This is using pharmacogenetics, for example, where you can do a cheek swab to better determine how your liver metabolizes different medication and can help your prescriber kind of finding a medication that you are more likely to tolerate. There's also having more intensive treatment. I talked about prolonged exposure that is usually done on a weekly basis, but there's studies that show getting prolonged exposure on a daily basis has been shown to be as effective. So it's doing the treatment more frequently, and this has also been shown to be for some of the other interventions like RTMS. Empowering strategies, shared decision making, and I've mentioned the importance of measurement-based care. That's when you're doing questionnaires, but you're reviewing those questionnaires with your provider to see what symptoms are improving and what symptoms are not improving. And then some of the enhancements that we are quite encouraged about is the whole area of psychedelic facilitated psychotherapy. And that's where you're combining a drug and a psychotherapy in order to get kind of a faster response. And then there's some of the newer emerging treatments that I didn't talk about here. Stellate ganglion block is another example. Next slide. So in terms of the key messages, PTSD is complex and often chronic. Comorbidity, very, very common, especially depression and substance use disorder. Always try to emphasize that you want to access treatment early. We want to make sure that the treatment is aggressive, but a focus on stabilization and not just symptom reduction, but also on recovery. You want to measure change using validated questionnaires and also maintain hope. Evidence-based treatments that we have now do work, and many people have recovered from PTSD with treatment. Being mindful that doesn't mean that they don't remember the traumatic event, but in terms of functioning. Next slide. These are resources that are available that will be posted, I guess, once the presentation is up online. The Mood Disorder Society of Canada, Atlas Institute for Veterans and Family, excellent website for, especially with a Canadian focus, the National Center for PTSD. Up to Date is a website where you can get information a lot on the treatment and medication. And then some of the clinical guidelines that are available. Next slide. And a special thank you to Mood Disorder Society of Canada for this presentation. And I have some information here on our website at the MacDonald Franklin Westside Research Center.
Thank you very much, Dr. Richardson, for that informative overview. At this point in time, I'd like to introduce Dr. Jenny Liu. She is going to be assisting Dr. Richardson with the Q&A. So please don't be shy and put your Q&A in the Q&A section at the bottom of the Zoom screen. We've got several questions here, so we've got 10 minutes to answer, so we'll go through as many as we can in that time. The first question is, I suspect my family or friend has PTSD. Where do I go to get help first?
I think that's a really good question. And first of all, is encouraging that individual to, if they have a family doctor, I can appreciate in Canada that can be challenging, but accessing first their primary care clinician is often very, very, very helpful to initiate that conversation, as they might be aware of other services. If they are a veteran, then referring them to Atlas Institute, where they can get some additional information. This is specifically, regarding certain kind of benefits and what's available kind of in Canada as a valuable source of information. But encouraging people to get the support and care, and reminding them that they do not need to be suffering in silence, but that there is help available.
Thank you for that. The second question is, thank you for presenting this information today. I would be curious to hear your perspective on the place and importance of patient and family education of the condition, treatments, expectations, etc.
I love that question. I think it's so important, and I think in my clinical practice, engaging the family is so important, and providing them with the same information that we provide to individuals who are suffering from PTSD. And also from my perspective is that as a clinician, I might be seeing the individual for maybe an hour longer at initial time, but their family members are living with them 24 hours and can provide a different opinion and view on how they're functioning at home. So I think it's so important, and also with the message that if one person, whether it's a mental health condition or a physical health condition, it does impact the entire family to different degrees. So very important to engage the family and have them as part of the treatment.
Thank you for that. The third question is, how long can PTSD last without treatment?
That's a really good question, and I do have a slide on that, meaning that a lot of the symptoms that people have after a traumatic event, would be considered normal, meaning somebody's involved, like for example, if they're involved in a motor vehicle accident, very common for the first couple of days, they might be reliving the event, they might feel nervous about the event, they might have some nightmares. Most of the studies have shown if the symptoms persist beyond 3 months, and that they're unlikely to recover completely on their own, which is probably why after traumatic event, we try not to diagnose too early, because it's very hard to predict those who will recover on their own. From my perspective, what's important is to look at functioning, not just if you have the symptoms. But I think if you continue to struggle and your symptoms or are not improving, or your ability to function continues to deteriorate, then it's important to be assessed, ask for help, and then because treatment, people do benefit from that support and treatment. Hopefully that helps to answer part of the question. But we've seen people, not to kind of, we've seen people who suffered for years and years. If you look at World War II veterans who have suffered for years and years, might have been functioning for years and years, but continue to struggle in silence.
Right. Thank you for that. The next question is, what is the evidence-based treatment success for family members?
That's a really good question. And maybe I probably need a little bit more information, because if a family member has a diagnosis of PTSD, they in reality would respond just as well as a veteran if we're looking from that perspective. In fact, civilian PTSD responds better to medication or talking therapy or psychotherapy compared to the veteran. But it might be that you're, if I'm answering it from that perspective, but definitely if sometimes family members are struggling from consequences of living with somebody that has PTSD, and they too should be, I would suggest, getting the support and services that they could benefit from.
Thank
And
you.
Doc, I can just add a little bit more to that as well. So there's limited evidence available for the effectiveness of treatment programs for families as well as couples. There's very few studies available, but generally speaking, there are some kind of efficacy stated by the evidence. But again, those are kind of emerging. We have couples treatment programs as well as family treatment programs. More and more of the research is leaning into kind of looking at the family as a whole, as opposed to, just treating veterans.
Thank you, Dr. Liu.
Yeah, thank you so much. Yeah, that's a very good perspective. There's some studies, conjoint treatment, where there's a veteran and a family member, usually spouse, who are receiving the treatment. However, most of the treatment has the identified veteran as the primary, but they're doing the treatment together.
Thank you for that. The next question, in the case of a client who we're working with classified information, sorry, let me restate that. In the case of a client who was working with classified information that contributed to their trauma, and they're not allowed to speak about it today, what would be your recommendation?
That's a really very good question, and we might not have all of that evidence meeting. There's some talking therapy that does not involve talking about the explicit details of the event, such as the cognitive processing therapy or the EMDR. So that might be an approach for some individuals. Also, if they're able to explore how the event has impacted them in terms of psychotherapy. There's also, which I've talked about before, there's evidence-based medication management, which obviously does not involve talking about the traumatic event, that might help some of the symptoms that they might have. So focusing on their functioning and making sure at the beginning, focusing on their comorbidity that they might be experiencing.
Great, thank you for that. And we have time for one last question. What precautions do you take with someone who wants to taper off their antidepressant or antipsychotic medication after trying it for about a year, but they just don't want to continue with it? What rebound symptoms could be expected, and how should they avoid them to ensure successful tapering?
Well, I can't really give specific recommendations that is that might be specific for one individual, because every person brain is slightly different and unique, and everybody responds differently to medication. I generally, in general, in my clinical practice, is to focus on developing a trusting relationship with the individual, and if there's are there certain symptoms somebody might be experiencing that they feel that they can't tolerate these side effects? And it's looking at both the benefits and risk of making a good judgment and decision based on the potential benefits of coming off a medication, but the potential risk of relapse when you're coming off a medication, and making a decision and using a very, very slow approach, but making sure that you have this ongoing follow-up, that if things change, that you can restart medication as required. And but it's developing that trusting relationship and to explore the potential benefits. Some people are able to come off medication and not have a relapse. Some conditions have higher risk of relapse, and therefore you need to be a little bit more cautious. So it really, I would suggest in all cases, is to work with the prescriber and then make a shared decision on both looking at the potential benefits of coming off and the potential risk.
Thank you so much, Dr. Richardson and Dr. Liu, for sharing this timely information with us. Diana, could you go to the next slide? There we go. So folks, please do take a moment and go into the chat and complete our anonymous survey. Your feedback is extremely important to us. Our next live seminar is scheduled for March the 26th, and it's featuring our mental health programs and supports. And at this time, I wanted to make an extra special thank you to our sponsor, the Royal Canadian Legion Dominion Command. So thank you all for joining us today, and have a great rest of your day.
Okay,
Bye for now.